This is part 2 of the schizophrenia series. Let's get started. As mentioned before, this is part 2 of the schizophrenia lecture. Assessment guidelines. What is the nurse looking for? She's assessing for command hallucinations. She's assessing for delusions, suicide risk, the ability of the person to maintain safety and health. Are they feeding themselves? Are they soiling themselves? Or, for example, if they are catatonic, are they able to change themselves, or do they need to be changed? Because then they're at risk for skin breakdown if they're pooping and peeing in their adult brief. You want to assess for medication compliance, make sure they're taking their meds and they're not cheeking them. Determine impact of symptoms, assess family knowledge and support, make sure that the family knows that this is a condition, this is an illness, and it's not something that's just in their head or that they're making up, and consider the cultural implications. For some cultures, illness is shameful, so make sure that you educate the individuals that this isn't a punishment, or that the family hasn't brought disgrace, or this person hasn't brought disgrace upon the family. That's just something neurobiological that happens. NANDAs in regards to schizophrenia: risk for self or risk for other directed violence related to history of prior suicide attempt or history of violence. Disturbed sensory perception. Remember that schizophrenia has to do with your 5 senses. So disturbed sensory perception related to biochemical factors as evidenced by responding to internal stimuli. So if they're sitting there and they're laughing to themselves, talking to themselves, that's responding to internal stimuli. Self-care deficit related to cognitive impairment as evidenced by a patient not eating for 3 days. A client states, I can't go into my bathroom because I saw a demon in the tub. Which nursing diagnosis reflects this client's problem? The key word here is they saw. And does seeing have to do with the 5 senses? It does. So therefore, the correct answer is disturbed sensory perception. Outcomes, identification, and phases of schizophrenia. If you work in a hospital, you're going to see them in the acute phase. If they are a danger to themselves or others, then in Florida, we Baker Act them. Basically, that's an involuntary hold. I'm sure other states also have involuntary holds, and the initial one is up to 72 hours, the BA52, and the 32 is the one where if after 72 hours this person is still deemed mentally incompetent and unsafe to release them, then they have to go to court where a second opinion, another psychiatrist basically says, yes, this person does need to stay hospitalized involuntarily, and then the judge has to agree, and the second psychiatrist, and the main psychiatrist. One way to remember the BA52 versus the BA32 is that 5 plus 2 is 7, and you hold someone for 72 hours with the 52, and the 32 involves 3 people agreeing that this person is not deemed mentally competent. The BA40 is a voluntary Baker Act. That's where the person says, I'm going to hurt myself, so I need to be hospitalized, so they walk themselves in to the Baker Act facility. What can you do? You want to monitor them for extrapyramidal symptoms. If the poor guy is like this, trying to write his name, then clearly he's having the pseudoparkinsonin-like symptoms, and we need to get him something for that. We need to bring it up to the doctor. If he's having loud lip smacking, then it's tardive dyskinesia, and the medication needs to be discontinued or weighed. Does the benefit outweigh the cons? So once again, medication, treatment adherence, relationships with providers, and them having a support system is very important, and community-based therapeutic services. You want to advocate for group and or individual psychotherapy. You want them to know about community mental health centers, day treatment, case management, housing, employment programs, and the National Alliance on Mental Illness has support groups, and once again, a support system is very important. For anything really, not just schizophrenia. Intervening with hallucinations. Remember that the hallucinations are real to that person. You want to focus on understanding the patient's experience and responses. You want to assess for suicidal or homicidal themes. Call the patient by name, speak simply and loud enough to be heard during auditory hallucinations. Use a supportive manner, maintain eye contact. However, common sense, if they're paranoid, you're not going to stare at them like this and just staring at them, because they think someone's after to get them, and you're sitting them staring at them, they think maybe you're the one that was sent to get them. and you want to redirect the patient's focus to the conversation as needed. So once again, because they are concrete thinkers, remember, speak very simply. Don't use highly elevated, eloquent language. Intervening with delusions, you don't challenge a delusion. Remember, a delusion is a false, fixed belief. Until reality testing improves, which this basically means reality testing is, for example, I think I hear a knock at a door. I go, I open the door, and there's no one there. I have intact reality testing because I can say, oh, there really wasn't someone at the door. I must have misheard, right? But with impaired reality testing is I believe something or I think I hear something, and despite the evidence to contradict that, I still believe it. So until reality testing improves, it is never useful to try and prove that a delusion is wrong. For example, if someone thinks they're pregnant, they're delusional, they're not pregnant. It doesn't matter if you give her 10 pregnancy tests and you put the pregnancy test in her face and you tell her, look, one line means not pregnant. They will always have an excuse. Oh, it's because I'm just pregnant, so we're taking the test too early. Oh, it's because those tests don't work. The only test that work is the one they do in the hospital. So it doesn't matter what you do, there will always be an excuse if they have impaired reality testing. So here's an example. Patient. You people are all alike, all part of the FBI plot to destroy me. Nurse. It seems to you like people want to hurt you. That must be very frightening. I will not hurt you, and we can work together to help you feel safer. So according to the textbook, this is considered therapeutic communication. You acknowledge what they feel, right? They feel like people are out to get them. You acknowledge the feeling behind it, and you clarify. You say, I will not hurt you, and you stay with them. And you say, and we can work together to help you feel safer. This is a very important concept that you need to grasp in regards to schizophrenia and the medication regimen. So there are two types of antipsychotics, first generation and second generation. Depending on your school, you may be taught about a third generation, but we will focus on first and second. The first generation antipsychotics were invented around the 1950s, so they're old, right? And think of it, when the first iPhone came out or when the first Android came out. The way I remember is these phones came out, they didn't work as good as what the ones do now. So the phones were a little glitchy. They crashed, they weren't as effective, they didn't do as much. Same thing with first generation antipsychotics. First generation antipsychotics, what you really need to know for an exam in regards to nursing school is that they only work for positive symptoms and you're more likely to get EPS from them. For this reason, we are less likely to use first generation antipsychotics routinely. Second generation antipsychotics are the first line treatment in regards to schizophrenia. So for example, a patient comes to the clinic and they're saying, I'm hearing auditory hallucinations. That's a positive symptom of schizophrenia. Even though it's a positive symptom and first generations treat positive symptoms, what am I going to treat this person with? A second generation antipsychotic. I'm not going to say, oh, I'm going to give you some Haldol. No. What I would give this person is something, a second generation. So maybe quetiapine or maybe Zyprexa. Risperidone, right? Those are second generation antipsychotics. So I can't reiterate this enough. Second generation antipsychotics, they're usually the first line treatment. They treat both positive and negative symptoms. Now, the issue with second generation antipsychotics is that they're more likely to cause metabolic syndrome. So they're less likely to cause tardive dyskinesia or EPS, but they're more likely to cause metabolic syndrome. What is metabolic syndrome? It's a cluster of disorders that occurs, and what happens to these individuals is that their blood sugar will increase, their blood pressure goes through the roof, then they start gaining weight down here, what we call central adiposity. And that is, again, a side effect of second generation antipsychotics. So we need to monitor these individuals. We need to educate them. Hey, we're going to put you on the doctor's putting you on a second generation antipsychotic. It's time. Let's say this person had a really fast metabolism before. I'm sorry, you can't eat at Burger King every day. It's going to be time to make some healthy changes. You need to exercise and start eating healthier. Because if we wait until this person weighs 400 pounds, it's always easier to prevent the weight gain versus let's try to lose the weight. And if this person starts gaining ridiculous amounts of weight, do you think that they're likely to stay on their antipsychotic? No. Then they get off of it, then they're going to decrease in their baseline functioning, and it's a vicious cycle. Second generation antipsychotics treat both positive and negative symptoms of schizophrenia. The way I remember is second generation atypical antipsychotic treats positive and negative. First generation antipsychotic is a typical antipsychotic and it treats only one, and that's the positive, okay? So if you're taking an exam, you can be doing like, okay, this is atypical, it works both. A client diagnosed with schizophrenia exhibits a flat affect, apathy, and avolition. Which medication should a nurse expect a physician to order to address these symptoms? Keywords here, AAA, right? All your A words are what symptoms, positive or negative symptoms of schizophrenia. They are negative symptoms. So we know these are negative symptoms and they're not talking about any positive symptoms. Therefore, I can eliminate Haldol and I can eliminate Risperidol simply because it has the word positive symptoms. I'm down to olanzapine and chlorpromazine. Yes, it's between one of these because these are negative symptoms, but remember, what treats negative symptoms? First gen or second gen? And the answer is second gen treats both symptoms. Now, you need to know this medication, and you need to know this medication. These are first generations, haloperidol and chlorpromazine. They are the most frequently tested first generation antipsychotics, so memorize them, right? And olanzapine is the right answer, or Zyprexa. We would give this to address the negative symptoms. Now you ask, what is EPS? EPS is a side effect, usually from first generation antipsychotics, okay? There's 4 types of EPS. Number 1, acute dystonia. I was just on the unit, I was acting out, I threw a chair at someone, I got shut up with some booty juice. And what's in our booty juice? By the way, that's what psych nurses sometimes would call it, or the client's like, uh-oh, he's acting out, he's getting some booty juice. Anyways, so what would I be getting? I'd probably be getting either Haldol or Geodon, and if I was getting Haldol, I would be getting Haldol, Ativan, and Benadryl. Side effect of Haldol, more likely to cause EPS. I get acute dystonia. Think of a stone, it's hard, it's fixed. I draw like this, and I talk like this, and I like this. I draw hurts. I can't close my eye. Remember that face. That's what their face will look like. Contracted. A sudden, sustained contraction of one or more muscle groups, and it's usually of the head or the neck. Akathisia is motor restlessness. They're just moving about. They're fidgeting. Be careful with this A word because it doesn't mean without. It's one of the few that don't mean without. So they're just moving. They can't sit still. They're pacing. They're fidgeting. That's akathisia. Pseudo-Parkinson's, all right. It's a group of symptoms that look like Parkinson's disease. Now, the reason that this happens is because the theory behind schizophrenia is that it is an excess of dopamine. So, what do we do if we want to, decrease these symptoms of schizophrenia, and we're big pharma and we're like, okay, if we think that it's because there's too much dopamine, I'm going to make a pill that lowers dopamine, right? Well, what is Parkinson's? Parkinson's is a deficiency in dopamine. So what happens is we decrease their dopamine levels and now we give them fake Parkinson's. So they're going to manifest all the symptoms that the people with Parkinson's have. So it's going to be the pill rolling or the tremors, right? The fine tremors, stooped posture, shuffling gait. They walk like a little robot, shuffling gait, and mask-like face. That's what the pseudo-Parkinson's look like. Just a caveat, remember that first gens do not raise blood sugar. That's more the side effects of the second. Tardive dyskinesia. It develops after a prolonged time of being on this medication. And what you need to know about tardive dyskinesia for nursing exams is we need to stop the med because it's potentially irreversible. It will start like lip smacking. So they'll be like, well, first it may start as tongue protrusion, simple like that. Or maybe their jaw is moving like, then. Now, what's serious about tardive dyskinesia is they don't realize that they're doing it. It's involuntary. So imagine going for a job interview, and because your provider, whoever it was, I will share the blame, whether it's a doctor, a nurse, a physician assistant, a nurse practitioner, didn't notice that you had tardive dyskinesia, and now your tongue is, or you're at the point where you lip smack or your tongue protrude, and you're like, and they're like, tell me a little bit about yourself, and you're like, well, I'm interested in this position, and then he's talking, so you're not cognizant of what's going on here, and you're just like, while the guy's talking, how likely do you think that person's going to get a job? Not very likely, and it's setting them up to be made fun of people. You know, we have some great people in the world, but we also have some very mean people that make fun of others just because they're different. And unfortunately, if someone's tongue protrusion is going out, people are going to look at that person and be like, what's wrong with that person? What a weirdo. You know, so we want to prevent all this from happening. Here's a visual of what tardive dyskinesia looks like. Pseudo-Parkinson's, the stoop posture, shuffling gait, rigidity, slow movement, tremors at rest, and pill rolling. Akathisia, restless, trouble standing still, paces the floor, feet in constant motion, rocking back and forth. Tardive dyskinesia, protrusion and rolling of the tongue, sucking and smacking movements of the lips, chewing motion. Acute dystonia, facial grimacing, involuntary eye movement, muscle spasm of the tongue, face, neck, and back, laryngeal spasms. That will be very dangerous. Then airway takes precedence. Once again, why is TD serious? Because it's potentially irreversible. It gets worse with prolonged or continued use of medication, and it greatly affects the quality of life of these individuals. What do you need to know about tardive dyskinesia? You need to know how to recognize it and know the appropriate intervention, which is stopping the med. Now this leads us to our next question. A nurse would recognize which medication as most effective in providing a client immediate relief from EPS. This is another medication that you need to know, you need to memorize. The answer is going to be benztropine, Cogentin. If we give this person Haldol, it's a first-generation antipsychotic, we're only going to make their EPS worse. Now, test-taking tip. This is not a select all that apply. You see this ending here, Pam and Pam? Just a little helpful tip. Lambs and Pams are benzodiazepines. Those are anxiolytics. Benzodiazepines, same answer, not a select all that apply. I'm going to eliminate these two. These work for anxiety. This would only make my EPS worse. This helps treat the tremors and it helps treat the pseudo-Parkinson's. Now, a little caveat. In textbook world, this does not help tardive dyskinesia. Maybe a provider may try it, but textbook world, test-taking world, tardive dyskinesia, and you give this, it's not going to do anything. This is not the treatment regimen for tardive dyskinesia. So anyways, benztropine is the answer for the pseudo-Parkinson's symptoms. Memorize this medication, I am telling you. Side effects of Cogentin, though, is can't see, can't spit, can't pee. If you could see, pretend this is my bladder, I'm holding my bladder, and can't poop. Back here, right? When I see can't see, I don't mean like I'm blind. I mean that Cogentin is anticholinergic and it dries you up like a little prune. So think of a raisin or a prune that's been dried up. I'm all sucked in, all my fluids sucked out of me, right? My mouth is going to be dry. My eyes are going to be dry. I'm not going to be peeing. I'm not going to be pooping. So that's why we say can't see, can't spit, can't poop, can't pee. Once again, agents used to treat EPS. This is what you're going to see most of the time, benztropine. This is another one, Artane, but mostly this is what we're talking about. You can give diphenhydramine in practice. That's what we do for emergency treatment orders. The reason for this is that, yes, this is an antihistamine, but this has anticholinergic properties. If you've ever taken Benadryl, you know that you wake up and your mouth is dry, and you're like, wow, my mouth feels like I've cotton in it. You need to know this slide also. Anticholinergic toxicity, they don't test as much on it. Older adults are at increased risk, and they will develop delirium and altered mental status. What you do need to know for exams and in real life also, even though it's very rare, is neuroleptic malignant syndrome. And it presents with altered level of consciousness, fever, and muscle rigidity. Those are your two keywords. Fever, muscle rigidity, because the other ones can kind of mimic what this looks like. And autonomic dysfunction. I actually had a gentleman develop this on my unit, and immediately he started, he was a little delirious, and he started almost laughing like a hyena and banging himself against the wall from one end to the other. Next thing you know, he's sweating, so he's taking all of his clothes off, right? We take his temp. When we did take it, it was getting around 102. Blood pressure through the roof. At that facility that I worked at, we only treated psych. We were not a medical facility, so immediately we called the ambulance and he was taken to the hospital. So yeah. And you need to know this. Agranulocytosis, A means without, granulocytes. So without granulocytes, what you really need to know is that this is a lowering of WBCs. But if you want to get really nerdy, your granulocytes, if you remember the acronym BEN, basophils, eosinophils, neutrophils, those are your granulocytes. That's what is lowered when people take Clozaril. And as a little fun way, let me see if I can, but you see here, it's flipped, but WBC and the C goes down with Clozaril. So that's how I remember that Clozaril affects WBCs. I was going to make a note and I just changed the slide because Clozaril is the trade name of the medication and clozapine is what you're going to see on your NCLEX. So remember clozapine, it's just longer to write with the little acronym. But the good thing about Clozaril and clozapine is that the first 4 letters, actually the first 5, Clozaril and clozapine, it's the same thing. So it's not like the generic and the trade is so different. Remember that this one causes a severe drop in WBCs, so they're going to get symptoms of infection such as fever, chills, sore throat, maybe some mouth sores, right? And then Geodon and Haldol you would need to get, in theory, especially with Geodon, they prolong the QT interval. So if you see this question on an exam, it would be important to get an EKG, and you would not give it to someone that has a history of cardiac issues. Other side effects of antipsychotics are sedation, orthostatic hypotension. It lowers the seizure threshold, sexual dysfunction, weight gain, and prolongation of the QT syndrome, which I mentioned already. Advanced practice interventions for these individuals. Remember, discharge planning starts on admission. We want to get together their medications. What meds are they going to be on? Can they afford them? Where are they going to go after we discharge them? Do they have a support system? Do they have a family? Are they going to come to their follow-up appointments? Do they have transportation? Do they know where their follow-up appointments are? And then there's groups such as SARDA, Schizophrenia and Related Disorders Alliance of America. There's individual and group psychotherapy, psychoeducation, family therapy, which is very beneficial. One of the textbooks that I was reading just discusses the family member having an aha moment when they went to these therapy groups. Evaluation and quality improvement. You want to evaluate a patient's progress regularly. Their progress may be erratic and or slow. You want to use evidence-based treatment. Monitor again for suicidal ideation and for side effects of medications. A client has been adherent with olanzapine Zyprexa 4 milligrams every night at bedtime for the past year. On assessment, the nurse noted that the client has bizarre facial and tongue movements, which is a priority nursing intervention. Okay, here's the key word, bizarre. What does that sound like? You should be thinking in your brain, chart of dyskinesia. What should that trigger? We need to DC the med. So the correct answer for this is notify the physician of the observed side effects and place a hold on the Zyprexa and request discontinuation of the medication. We would not give Cogentin because it's not pseudoparkinson's, or it's not dystonia, and it's not akathisia. Who says nursing is stressful? I'm 39 and I feel great.
Thank you so much for watching. Make sure you hit the like and subscribe button.